Hi everyone, welcome back to my channel. As you can see, we have a special guest here, Mr. Bones. He's going to try to help me explain some of the things that I've learned in my PM&R rotation. And for those of you who don't know, PM&R stands for Physical Medicine and Rehab. These physicians are also known as physiatrists. They do a variety of different things. They can work in a clinic, work in a hospital setting. It's more than physical therapy. It's actually they deal a lot with patients with musculoskeletal system and the nervous system, with joint pain and lots of different things. So one of my friends who is actually applying to PM&R explained to me, or summed it up really well for me. She explained that PM&R is basically primary care physicians for patients who have like some neurological defect, like patients who've been through a stroke or kids who have cerebral palsy, amputees. They would come to a PM&R doc regularly to check up and see how they're doing and for them to manage their care. It's hard for me to explain the big general gist of what PM&R is because it encompasses so many things, and the physicians that I shadowed actually did a pain fellowship. So the two DOs that were my preceptors, one went to a PM&R residency and then did a fellowship in pain. The second DO was an anesthesiologist who also did a year fellowship in pain, and now they own a clinic together, a pain clinic together, and their goal is to own a surgery center. So obviously a lot of what they deal with is pain. So I can't give you more of a background of what general PM&R is. But I do know that if you want to go into PM&R, usually you would have to do 1 year internship and then 3 years of residency. And then if you wanted to do a fellowship in pain, it would be an additional year. So the patient population that I saw during these 2 weeks were a lot of people who came in with chronic pain, whether it be chronic back pain, neurologic pain, fibromyalgia, just lots of different things. And I wanted to explain other possibilities of treating pain without actually using opioids. With all the new rules going on and regulations, we're trying to steer away from opioids because we've learned that pain medication is just like a band-aid, and it's only good for acute trauma or acute pain, not like after surgery or after some sort of trauma, but it's not necessarily good for long-term management of pain. Like a really good example, I see a lot of patients who have fibromyalgia who come in and think that they need all these opioids when that is not necessarily the case. That is not how you treat fibromyalgia at all. It's actually naloxone. Or people who have a herniated disc and they think that they just need to take pain medication, and that there's other ways to treat that sort of pain. So let's move on to Mr. Bones and I'll show you some of the things that I've learned. Today I want to specifically talk about back pain and injections that you can do to relieve this back pain. And injections can last 3 months at a time, 6 months at a time, years at a time. Some people only need one injection and they're good for life. Some people it doesn't work at all. So it just depends on the patient, and it's one of the options that you can use before going to opioids. So say someone comes in with back pain, obviously you have to do a neurological exam and you have to feel their back. Usually I go down the spine and see if there's any restriction, and then usually they'll point out to a spot that is painful, or they'll describe where the pain is. If it's somewhere away from the spine, you know it's probably more musculoskeletal or fascial. For those, we call them trigger points. And so you would go in and inject the actual trigger point. Research has shown that there is no difference in pain relief compared to steroid injections, injection of lidocaine, or just dry needling. And so people have tend to stray away from steroid injections right into the muscle just because it can cause muscle atrophy. Now let's zoom in a little bit so I can show you more of injections on the spine. So here we have the lumbar spine, and usually when we do steroid injections, they're always under fluoroscopy, which is x-ray basically. And on the x-ray, we are usually looking for the Scotty dog. It's kind of hard to see when it's not on radiograph. I will try to insert a video or a picture somewhere here so you can follow along. But the nose of the Scotty dog is right here. Also, anatomically, that's the transverse process. On radio, you can't see it here, but on radiograph, right here, that's the pedicle, and that would translate to the eye of the Scotty dog. Right here is the superior auricular process, also known as the ear of the Scotty dog, and then right below that, this is the leg of the Scotty dog, which is the inferior auricular process. And obviously these are the spinous process, but I hope you guys can see that. So these are landmarks that you would use to determine where you would put the injection. So say a patient was complaining of back pain that is localized to the lower back. It's non-radiating, but it just hurts in this area. And it hurts with extension, which means bending back. If you can see, bending back would actually irritate these facets. That can be due to a spondyloarthritis or some sort of arthritis or inflammation of these joints. So what these physicians can do is go in and actually inject steroid into these joints to decrease the inflammation. And let's zoom in so I can show you what that looks like and what we're looking for. There are three actually types of injections that you can do for the facets that is causing pain localized to the lower back or any part of the back basically, but localized and non-radiating. So you can inject the facet itself to decrease inflammation. Or second, you can do a medial branch block, and that means that there are medial branches coming from, say, this is 1, 2, 3, 4, 5. So say there's a medial branch coming from L1 that is stimulating pain in L2. And so to get pain relief in L2, we want to block the medial branch in L1 stimulating this. And how we do that is there's a medial branch coming out from the top of the eye of the Scotty dog, and you aim for right there, inject right there in hopes that you would block that nerve. And if you are able to get pain relief for a certain amount of hours, then we know that that nerve is causing some sort of pain. We would do that twice, and then if all goes well and it enables you to have pain relief, then we would go on and do an ablation. And that means that you would basically burn that nerve. Some people last 6 months, some people last a year, some people last a lifetime. It just depends on when the nerve grows back. The other complaint that people usually get is like a sciatic type of pain, and pain is worse bad in their back and radiates down their legs. It can be one side or both sides, and worse with flexion. And if you can see, these discs are in between each vertebral body. Flexion would cause bulging in the back and compression of the nerves, and we call that a radiculopathy. An injection that we can use to treat this type of pain is an epidural injection, and usually we do it transforaminal. So epidural steroid injections, we usually do it transforaminal, which means through the foramen, and we aim for right under the eye of the Scotty dog. So usually when you do an LP, lumbar puncture, you would have them bend over and you go in this way. For transforaminals, since we're trying to get one side or the other side, we can do them bilaterally, but we would do it transforaminally. So on x-ray, we would aim for right under the eye of the Scotty dog, and we would go into this area, inject fluoro to see if we're in the right space, and then we would do the injection. So another type of pain that we treat is called complex regional pain syndrome. We're unsure of how people actually get the pain because there's two types, one's traumatic and one's non-traumatic. We just know that it's sympathetically mediated. And one way that we found that really helps for this type of pain is actually implanting a spinal stimulator. I met this guy who had complex regional pain syndrome, and he couldn't work for 20 years. He had really bad pain in his legs, he couldn't walk, and after the pain stimulator, he was able to walk in 2 days, and within 9 days he was back to working. And this was after 20 years of just not doing anything. So it's amazing what these new technologies can do nowadays. So those are some of the things that I've learned in my PM&R rotation. Hopefully you learned something as well. So if you like this video, please give it a thumbs up. And if you haven't already, please subscribe, and I'll see you guys all next time.